whenever heart failure occur, whenever the heart is failing, unable to contract, unable to do the systole, most commonly heart failure occur of the left side, but it can be of right side, but most commonly for the sake of understanding, we will take in consideration the left side. Left side is not contracting, showing systolic dysfunction. We will consider that. So whenever the heart failure occur, whenever the left heart failure or heart failure is occurring, body will compensate to that. Body will try to compensate that. Okay, the great God has given compensatory mechanism. What are the compensatory mechanism? God has given us 3 compensatory mechanism. One is good, 2 are bad. Now please understand, because complete therapy of heart failure is depending on the compensatory mechanism. If you don't understand the compensatory mechanism, you will not have an understanding of the heart failure. Okay, heart failure drugs. Please see. So what is compensatory mechanism? Imagine when the heart is not contracting. Imagine the left ventricle is not contracting. What will happen? It's an emergency. It's an emergency situation. Imagine the left ventricle is not contracting. So blood is not moving in the aorta. Blood is not moving in the aorta. Blood is unable to go in the organ. All the organs will receive less blood. It's an emergency situation. Whenever such emergency occur, what happens in emergency? You tell me. I told you. We are in autonomic nervous system. We are having 2 systems, parasympathetic and sympathetic. In emergency, sympathetic stimulation occur. So whenever the left ventricle is not contracting, imagine a human being in which suddenly left ventricle stop contracting, or less contraction, subtle contraction, or no contraction. What will happen? It's an emergency. Blood is not coming in the aorta. Less blood is coming in the aorta. All the organs are in hypoxia. Oh my God, it's an emergency. So the body will compensate by doing sympathetic stimulation. Got it? So body may compensatory mechanism will occur. Whenever heart failure occur, the contractility is less. The left ventricle is contracting less. So it's an emergency. At that time, the compensatory mechanism will come in the role. 3 compensatory mechanisms will come in the role. All are due to sympathetic stimulation. You know sympathetic stimulation? I guess if you have watched my lecture on ANS, you may be knowing this chart. The alpha receptors and beta receptors. You know where are the alpha receptors present in human body? Where are the beta receptors present in human body? Have you seen this chart previously? These are the organs on which alpha and beta receptors are given by the God, and they get activated during emergency. So which of them will get activated? 3 of them will get activated on 3 organs. So first of all, on the heart, the God has given beta 1 receptor. They will get activated. Can you see the beta 1 receptor on the heart will get activated during emergency when the heart is not contracting, and that will stimulate the beta 1 receptor. That will increase the heart rate, force of contraction, and velocity of contraction. So the failing heart will come again. So the great God has given us this mechanism. Imagine if someone's heart is failing. Can you see this diagram? In everyone's heart, your heart, my heart, in all of our heart, the God has given beta 1 receptors. Beta 1 receptors are present. Till the left ventricle contracts normally, beta 1 receptors are not stimulated. But imagine if someone's left ventricle is not contracting. What will happen? If ventricle is not contracting, blood is not going in the aorta. Blood is not going in the aorta. So all the organs are receiving less blood. Within few seconds only, the sympathetic stimulation will get activated. Okay. And noradrenaline will come in the blood. Okay. Noradrenaline will be synthesized. That will come in the blood, and that will come and bind with the beta 1 receptor, activate the beta 1 receptor. As soon as the beta 1 receptor on the heart will get activated, they increase the contractility, they increase the force, they increase the velocity. So all the things will be increased, and the failing heart will be revitalized. So it is a compensatory mechanism given by the God. Can you see? But it will hold only for few minutes. You will say, ma'am, then why therapy is required? You are saying whenever the heart is unable to contract, God contracted by giving the compensatory mechanism. So imagine here in this heart, the left ventricle is not contracting. Imagine. So what will happen? The sympathetic stimulation will come in the role. On the wall of the left ventricle, we are having beta 1 receptor. Imagine these are beta 1 receptor. So the sympathetic stimulation will come in the role. Noradrenaline will come in the role. Noradrenaline will come, bind with the beta 1 receptor, activate the beta receptor, and increase the contractility again. So the heart which was failing, it start contracting again. But it will only for the few minutes or less time. It is not permanently on compensation the person can survive. So for few minutes, the heart will be revitalized. So that is a good thing. That is a good thing. You got my point? So whenever the heart is failing, 3 things will occur. I told you one thing is good, but 2 of them are bad. First, understand the good thing. So the beta 1 receptor on the heart will get activated, and they increase the cardiac output. This is good. This is good. It's a good compensatory mechanism. But two bad compensatory mechanism also occur. Okay, listen, when the noradrenaline is coming in the blood, during emergency, noradrenaline is coming in the blood. This noradrenaline binding with the heart, it's good. But this noradrenaline will go. It is binding with the heart, it's good. But it will go to the kidney also, and it will go to the blood vessel also. Okay, on the kidney, we have beta 1 receptor, like heart only. Like heart only, kidney also have beta 1 receptor. Blood vessels have alpha 1 receptor. So noradrenaline bind here also and here also, and see the consequences. You understand the consequences. When the noradrenaline binding stimulating the beta 1 receptor of the kidney, you know, beta 1 receptor of the kidney are present on JJ apparatus. They will get activated and they will secrete renin in the blood. Yesterday I taught you this session. How many of you were present yesterday? So I taught you the renin will come in the blood. Once the renin will come in the blood, renin convert angiotensin 1, angiotensinogen to angiotensin 1. Angiotensin 1 will be converted to angiotensin 2 by ACE enzyme. Ultimately, angiotensin 2 will be formed. Angiotensin 2 will secrete aldosterone in the blood, and aldosterone causes sodium and water retention. You got my point? So more and more sodium and more water retention will occur in human body. So is it good or bad? You will say, ma'am, it's bad. Why it's bad? Imagine the heart is failing. Heart is unable to perform the function. Please understand, the left ventricle is unable to perform the function, and you are increasing sodium and water in the blood. You are increasing more sodium, more water, more venous return. So itna bhi nahi kar pa raha. Heart is unable to do this function also, and you are increasing the load of the heart. You are increasing the workload on the heart by giving more sodium and more water. So more fluid has to be ejected. Heart is failing. We have to reduce the load. We cannot increase the load. But via this mechanism, we are increasing the load. We are increasing the preload. Because more sodium, more water, more preload. More preload, so it is increasing the workload on the heart. So that is not good. That is not good. Not only this noradrenaline, which is coming in the blood during emergency, it will go on blood vessels. You know the blood vessels of the heart. Can you see the blood vessels? Let me show you it here. Just a second. These are the blood vessels of the heart. You can see the beta 1 receptors are present here on the wall of the heart, and beta 1 are present on the kidney. So noradrenaline first come and bind with the beta 1 on the heart and increase the contractility. That's a good thing. Noradrenaline go and bind with the beta 1 of the kidney, okay, and secrete renin. Renin convert angiotensinogen to angiotensin 1. Angiotensin 1 will convert into angiotensin 2. Angiotensin 2 will cause secretion of aldosterone from the kidney. Secretion of aldosterone from the kidney. This aldosterone causes sodium and water retention. We're getting my point. This aldosterone will cause sodium retention and water retention. Say yes. So sodium and water. So more sodium, more water, it will increase the preload on the heart. So that is not good. That is second thing. Now noradrenaline bind with the alpha receptor also. Alpha receptor present on the veins and the arteries. Appreciated. Got it? Utrina, Sunita, Soumya, Mubarak, please see. Alpha receptors are present on the veins and the arteries. So noradrenaline activate the alpha receptor on the blood vessel. And what does it causes? Vasoconstriction. Vasoconstriction of the veins, vasoconstrictions of the artery. So you tell me what will happen. Sunita, what will happen? Veins will vasoconstrict. You tell me what will happen. So there is alpha 1 receptors present on veins as well as arteries. So veins as well as artery undergo vasoconstriction. When the veins undergoing vasoconstriction, I told you now, veins are the capacitance vessel. If they are undergoing vasoconstriction, all the blood will be ejected in the right auricle. I mean, it is increasing the preload, which is again not a good thing. The heart is failing. It's not a good thing. And imagine the artery. Can you see this is the artery, the aorta? It is causing vasoconstriction. So it is increasing the afterload. It is increasing the afterload, which is again not a good thing. So we are increasing the preload or afterload via these two mechanisms. So these two mechanisms are increasing the workload of the heart. They are increasing the workload of the heart. So this thing is good in compensation, but these things are not good in the compensation. But the point is that all occurs together. Whenever noradrenaline come in the blood, it will bind with all. You can see once the noradrenaline is in the blood, it will bind with the heart. I want it to bind with the heart so it can increase the contractility. But noradrenaline bind with the artery and vein also, and it will bind with the kidney also. I cannot stop it. So noradrenaline will bind with all three things. With the beta 1 receptor on the heart, with the beta 1 on the kidney, and with the alpha on vessels, arteries as well as veins. So these two are leading to increased workload. How many of you got this? How many of you got it? If you got this, I will teach you 6 categories, 6 type of drugs acting on the heart failure in this master diagram. This is my master diagram for today. In this master diagram, we will study 6 categories of the drugs. You are getting my point? The 6 categories of the drugs which are acting for the heart failure. Understand this compensatory mechanism. Please do understand. So imagine if someone is having heart failure, imagine the left ventricle is not contracting. It's an emergency situation. The left ventricle not contracting. Imagine someone's left ventricle not contracting. So all the organs are not receiving blood. It's an emergency. Come on, dead emergency. At that time, sympathetic system will come in the role. So because in emergency, we know sympathetic system comes in the role. It's an emergency. Sympathetic system will come in the role. When the sympathetic system will come in the role, noradrenaline will come in the blood. This noradrenaline will go and bind with 3 receptors. Once it will bind with beta 1 receptor on the heart, then it will bind on the beta 1 receptor on the kidney, and then it will bind with the alpha receptor of the blood vessel, that is arteries also, veins also, arteries as well as veins, alpha receptor of the blood vessel, I mean. Okay, so this one is good, but these two are bad. How? Understand it. So if this is suppose beta 1 receptor on the heart, beta 1 on the kidney, and alpha on the artery and alpha on the vein. So if noradrenaline coming and binding with the beta 1 of the heart, it is increasing the heart rate, it is increasing the force of contractility, and it is increasing the velocity of conduction. So it's good because heart is failing. I want it to increase the force, contractility, velocity because heart is failing. I want it to get increased. So this is happening and it's good. This one is good. But when this noradrenaline coming and binding with the beta 1 receptor of the kidney, it secretes renin in the blood. Renin convert angiotensinogen to angiotensin 1, angiotensinogen to angiotensin 1, angiotensin 1 will get converted to angiotensin 2. Angiotensin 2 causes release of aldosterone, and aldosterone causes sodium and water retention. So heart is unable to perform the function, it's failing. पहले तो इतना तो कर ही नहीं पा रहा, ऊपर से तुमने और सोडियम और वाटर ला दिया. So you are giving more sodium and more water. Heart is unable to perform this function only, normal function, and you are overloading it with more sodium, more water. Heart is already failing. If someone is weak, we will give the person less work. We will not overload the person ki you do this also, you do this also. Person is unable to perform the normal function, and you are overloading the person by giving more work. So that is what here it is happening. So we are increasing the preload. We are increasing the preload. More water, more sodium, increasing the preload in a failing heart, which is not good. You got my point? And what will happen when this noradrenaline go and bind with the alpha receptor on the artery and vein? Both of them show vasoconstriction. When the veins show vasoconstriction, it increases preload. And when the arteries shows vasoconstriction, it increases afterload. So again, we are increasing the workload on a failing heart. The heart is already weak, unable to perform the function, and we are giving more and more work. So these two things are not good. Everyone got it? Yes or no? Shall I explain now? Shall I proceed? Yes, absolutely right. So that is the thing. If you got this, you will be able to understand it now. Okay, so the same thing I have given. You see, whenever the heart failure is there is decreased contractility of the left ventricle. So it's an emergency. The compensatory mechanism will come in role. During compensation, the sympathetic activity will come in role. First of all, the sympathetic activity, I mean noradrenaline will come, and that will bind with beta 1 receptor on the heart. That will increase the cardiac output. That will increase the heart rate. That will increase the force of contraction. That will increase the velocity of conduction. Everything is good. Cardiac output is increased and compensation occurred. I am happy. We are happy. Let's make this smiley. Okay, we want this to happen. Okay, but two more things will happen that we do not want. So can you see this one? I have marked with the red color. I want this to happen. Okay, this one, the beta 1 receptor on the heart, but the alpha 1 receptor on the blood vessel and the beta 1 on the kidney, I do not want this to happen. The blue one, these two are bad compensation. So when noradrenaline come in the blood, this noradrenaline also bind with alpha receptor on the blood vessel and beta 1 receptor on the kidney. Okay, because of both of them, the workload on the heart is increased. You know what will happen when the workload on the heart is increased? Heart is unable to perform this function, and you are giving more workload to the heart. So heart will try to compensate by causing thickening of the left ventricular wall. In the left ventricular wall, it keep on thickened, which is not a good thing. No, thickening of left ventricular wall is a bad thing. Okay, so left ventricular wall keep on thicken, and the person can die. This is the most common cause of death in heart failure, congestive heart failure, because the left ventricular wall is thickening. Why it is thickening? To compensate, because the heart is already weak and you are giving more work. So heart will thicken the left ventricular wall so it can contract more. It keep on thickening. So left ventricular hypertrophy will occur. So you can see ultimately these one I have marked with a blue color. You can see these both. You can see these both are leading to increased workload over the heart. And ultimately, it is leading to hypertrophy and mortality. Mortality in CHF. How many of you got it? People, kindly respond. You want me to continue? Kindly respond. Anyone have any confusion? Can we proceed? So that is the thing which is happening here. Now, there are two types of heart failure. I will teach you treatment of two types of heart failure. Why these annotations are carried? Just a second. I will teach you treatment of two types of heart failure. Acute heart failure and chronic heart failure. Acute heart failure, chronic heart failure. Yes, in compensatory mechanism, noradrenaline secretion occurred immediately whenever heart failure occur. Yes, yes. Himalaya, very good question. That's what I'm explaining you in acute and chronic. Now listen. Your question is very good. That's what I want to explain. So as soon as the heart failure occur, the noradrenaline come in the blood immediately. It's an emergency condition. Okay, sympathetic stimulation occurs immediately. So immediately it will increase the cardiac output by binding with beta-1 receptor on the heart. That occurs immediately, and that will help in acute heart failure. That will help in acute heart failure. So in acute heart failure, we don't have the hypertrophy. Okay, we don't have, because for doing the hypertrophy, it take years. It is not one day job. The left ventricular wall get thickened in many years. Okay, so this will also happen. This will also happen. So on one side, basically we are doing three things over here. Himalaya, we are doing three things. So as soon as the left ventricle is unable to contract, imagine someone's left ventricle, okay, unable to contract. It's an emergency. So the blood is not going in aorta. All the organs are not receiving the blood. It's an emergency. Sympathetic stimulation will come in the room. Because of that sympathetic stimulation, noradrenaline will come in blood. Okay, that noradrenaline will go and bind with the beta-1 receptor, increase the contractility for the next few little bit time, like maybe few minutes or few hours, but not permanently. Person has to take the treatment. Okay, but this compensation holds good for the next few minutes. Okay, this is good. This is good, increasing the contractility. But this noradrenaline will go and bind with the beta-1 receptor on the kidney, as well as alpha receptor on the veins and alpha receptor on the arteries, which is not good. Because beta receptors on the kidney, once it gets stimulated, they secrete renin, and ultimately sodium water retention will occur. So heart is already failing, and you are giving more work by giving more sodium and more water. Okay, and alpha receptor will cause vasoconstriction. I mean, venoconstriction as well as arterioconstriction. It's difficult, people. Venoconstriction means veins are contracting, so blood will be drained. So heart is unable to perform this function only, and you are giving more blood. By contracting the veins, you are increasing the preload. And if arteries are contracted, aorta is contracted, this left ventricle is unable to push. Already it's in failure, and you are contracting the aorta. So left ventricle has to do more effort to push the blood in the aorta. You are increasing the afterload. So it's not a good thing. The person who is already weak, you are giving more and more work. You do this also, you do this also. Person will die. Okay, gradually, person will try to compensate. I am already weak. I am unable to do normal work also, and they are giving me more work, more work, more work. So no, that's not humanity. So heart is failing. This person's heart is unable to pump normal blood only, and you are giving more blood to pump, and you are increasing preload, you are increasing afterload. Got my point? So it will try to keep compensating. So it will take years. It is not immediate. It will take years to compensate. It will keep on thickening its left ventricular wall, and one day this person will die. Okay, because of thickening of the left ventricular wall. If person will not take treatment, I mean, if the person is taking adequate treatments are available, I will come on the treatment quickly. Okay, so in acute heart failure, that's what I'm telling you. So in acute heart failure, only blood is unable to pump efficiently, but hypertrophy have not occurred. So if the patient is coming to us in acute heart failure, what is our main motto to treat? Main motto to treat to increase the contractility of the heart. So we will give inotropic drugs. In acute heart failure, this is occurring. This is occurring in acute heart failure. That's immediate. What you are asking is immediate. So we will give inotropic drugs that will increase the contractility again. Currently, the contractility is increased by the compensatory mechanism, by the beta-1 receptors. But it is only for a few minutes now. We have to give inotropic drugs that increase the contractility till the failing heart is coming again. Okay, it is becoming strengthened again. Got it? So here we will give inotropic drugs to increase the contractility. And number one, the first drug is inotropic drugs that increase the contractility. Okay, and since the left ventricle is not pumping, so blood is not going forward, the blood is going backward, and blood is going in the lungs and getting accumulated. So congestion is there. So we will give diuretics to decrease the congestion. You are getting my point? So in acute heart failure, we give two type of drugs. Number one, inotropics, and number one, diuretics. How many of you got it? But in chronic heart failure, this have already occurred. This have already occurred. So here the main motto of treatment is different. Here main motto of treatment is not increasing the contractility. In chronic heart failure, main motto is to reverse this. Main motto is to reverse this hypertrophy which has already occurred, and at least halt it if you can't reverse it. So that is the main treatment. We will take the drug that will block the alpha and beta receptor. We want to block this alpha receptor. We want to block this beta 1 receptor on the kidney, so that this do not occur, this all do not occur. We do not want to give more work to a failing heart, so that hypertrophy do not occur. So that is the main motto in the chronic heart failure. So we have to see person is an acute heart failure, which is an emergency, or chronic heart failure, which is not an emergency. The aim of treatment is different in both of them. How many of you got it? Himalaya, you got it. Sunita, others, you got it? Give me a thumbs up. Can we go ahead? Now, New York Heart Association, NYHA, New York Heart Association, has given a classification of heart failure. We divide the heart failure in 4 categories: category 1, category 2, category 3, or category 4. Based on its severity, we are giving it in 4 category. If the person have symptoms of the heart failure, even at ordinary activity, it's category 1 heart failure. NYHA class 1 heart failure. Okay. If the person have symptoms, I'm sorry, if the person do not have symptom at ordinary activity, but persons have symptom at a work on greater than ordinary activity, whatever is my routine I'm doing, I don't have any symptom. But if I'm exaggerating, I'm doing some extra work, then I have the symptom, it's category 1. If I have the symptom even at routine work, okay, so that is category 2. Okay, because of my heart failure, I'm doing limited work. Because whenever I do the work, I'm having the symptoms. So most of the time I'm resting. So it is category 3. Even at resting, if I have the symptoms, it is category 4. I hope you got it. So these are the 4 categories. Okay. If someone is doing extra work from the routine, then the symptoms are there, it's category 1. If someone is doing routine work, then the symptoms are there, it's category 2. If someone is doing less work, most of the time is person resting and doing less work, not even routine, because the person is doing the work, person is having the symptoms, it's stage 3, category 3. And even at rest, if the person have symptoms, it's stage 4. So you should know this classification. You will read it again, I guess, in medicine, but you should know it. Now let's start the pharmacology. This was an overview, people. Now I will start the pharma. I will teach you the drugs for heart failure. So let's start the drugs for the heart failure. Have a look. So we are dividing the drugs of heart failure in 6 categories. I will teach you all 6 categories. Please have a look. Okay, the drugs for heart failure, we are dividing in 6 categories. What are the 6 categories? Have a look here. You can see the look. So you can see we are having inotropic drugs. We are having vasodilator. We are having diuretic. We are having aldosterone antagonist. We are having RAAS inhibitor, which I taught you yesterday, and beta blocker. You will say, ma'am, how to understand all these categories and how to learn that? It's very easy. How many of you understood this? If you have understood this now, you are allowed to sit for the next 2 hours. Otherwise, you will not understand anything. This compensatory mechanism, this is my master chart. I will teach you my 6 drugs in this chart. I will teach you all 6 drugs in this chart. All these, I will prove how they are helpful over here. Okay, so this is the disease. What is the disease? The disease is heart failure. There is decreased contractility. The left ventricle is not contracting. It can be right ventricle also, people, but most commonly it is left ventricle. That's why I'm using the terminology left ventricle. So decreased contractility of the left ventricle, suppose, is there. Okay, that is the disease. That is the disease. Okay, for that we give only one drug. Now, what is the problem? We will reverse that. Say the problem. Sunita, what is the problem? Himalaya, what is the problem? The problem is contractility is less. The left ventricle is unable to contract. See, this is the left ventricle. It's unable to contract. So by any mechanism, if you increase the contractility of the left ventricle, such drugs are known as inotropic drugs. Inotropic drugs. Inotropic drugs are the drugs that increase the contractility of the heart. So my first category, the foremost category I will start is inotropic drugs. Yes, Sunita, absolutely right. So here contractility is less. Now you increase the contractility via giving inotropic drugs. We will give inotropic drugs to increase the contractility. That is my first category. Okay, so first I will teach you inotropic drugs, which is the most important drug in this chapter. I will teach you in detail. But the remaining 5 categories are to reverse the compensation which is happening. We are not treating the disease. We are reversing the compensatory mechanism. You can't understand the remaining 5. This is inotropic. These remaining 5. You can't understand remaining 5 unless and until you understand this compensation. So that's why I took an hour to explain you the compensation. Now you will understand the remaining 5 also. Okay. Now, can I block alpha receptors? Yes, they man, give alpha blocker. If you are giving alpha blocker, alpha receptors on the arteries and veins will be blocked, and preload and afterload will not increase. So alpha blockers will be helpful. Yes or no? Say yes. Beta 1 blockers on the kidney. So we are giving beta blockers also. So we will give beta blockers also. That will block the beta 1 receptor on the kidney. So renin will not come, aldosterone will not come, and sodium water retention will not occur. So alpha blockers are helpful. Beta blockers are helpful. Wait. Can I give RAAS? That is RAAS inhibitors, renin angiotensin system inhibitors. Yesterday I taught you renin inhibitors, ACE inhibitors, okay, ARBs, that is angiotensin receptor blockers. These all are RAAS inhibitors. They will inhibit the activity of renin. So we can give RAAS inhibitors. So there will be no renin. There will be no renin, no aldosterone, no sodium water retention. Or else we can give aldosterone antagonist. Okay, it's better if you can block beta. If you are blocking beta, nothing will happen. Okay, suppose I'm giving beta blocker. So nothing else is required. But sometime we are not blocking beta. We are not blocking beta. We are blocking renin. So we are giving a RAAS inhibitor. If we are not blocking renin, we are not blocking beta, we are not blocking renin. So we give aldosterone antagonist. So antagonize the effect of aldosterone. Okay, if you are not even antagonizing the effect of aldosterone, either give beta blocker, then nothing else is required. Or give RAAS inhibitor, then nothing else is required. Or if you are not doing so, give aldosterone antagonist, then nothing is required. But still, if you are not doing so, finally, sodium water retention will happen. So you have to give diuretics to excrete the extra sodium and extra water in the urine. So finally, you will give diuretics. So say the 4 categories of the drug. Who will say the 4 categories? Say, ma'am, beta blocker, RAAS inhibitor, aldosterone antagonist, and diuretics. Okay, these 4 categories. And alpha blockers from here. Okay, 5. Okay, 5th category. Inotropics drugs we are giving here. What else? Yeah, and we can give vasodilator. If you are giving alpha blocker, imagine, if you are giving alpha blocker, then nothing is required. But suppose if I'm not giving alpha blocker, so vasoconstriction will occur, no? In the artery also, in the vein also. So I will give vasodilator. Let's give vasodilator. Arterial vasodilator or veno vasodilator. So these all are the drugs. People, have a look. See this chart very clearly, completely. Everyone see, and see my next page. In the next page, I will draw the 6 drugs. In this only, I will draw. These are my 6 drugs. Have a look. This is the same classification. Only the drugs are inserted. Have a look, people. So first of all, you give inotropic drug to reverse the disease. What is the disease? You told me the disease. The disease is decreased contractility. So you give a drug to increase the contractility. Such drugs are inotropic drugs. That is the first category. The remaining 5 category are reversing the compensation. What are those? You should understand the compensation. If you don't know, the students who don't know compensation, they think, ma'am, why we give diuretics if the heart is failing? What is the connection? Heart is unable to pump, but diuretics excrete water and sodium in the urine. What is the connection of diuretics with the heart failure? This is the connection. Why we are giving RAAS inhibitor? Why we are giving aldosterone antagonist? You can understand them all. So you can see alpha blocker here, beta blocker over here, alpha and beta blocker taken together. Okay, number 1. Arteriodilator and venodilator taken together. Okay, here RAAS inhibitor, aldosterone antagonist, and diuretics. Count them, the 6 categories. Okay, the 6 categories. Okay, say yes. Okay, what you are asking? Ma'am, if give beta blocker, it will block the kidney beta receptor. Yes. That's very good question, Himalaya. I'm very happy that you are understanding. I was expecting someone should ask this question, and I was waiting who is understanding. Yes, very good. So the question is very correct. Himalaya is asking that if we are giving beta blocker, so beta blocker is blocking in the kidney. Why not beta blocker is blocking in the heart also? Okay, so we will give selective beta blocker. We will give beta 1 selective, and only few drugs are there that will have more. This is also beta 1, this is also beta 1, I agree. But we will give such a beta blocker, they will have more action on the kidney as compared to heart. In the past, we don't use beta blocker having this thought, whatever you have said. So we don't give beta blocker because we thought beta blocker will block the kidney, but beta blocker will also block the heart also. So cardiac output, which is increasing, that will fall. But having this thought, but we have, everything is risk and benefit analysis. So I know giving beta blocker will have little bit of harm over here. Considering this, I will agree. But we can compensate that by giving the inotropic drug. This loss or this harm, we can compensate by giving inotropic drugs. Okay, but if you are giving beta blocker, this complete thing is blocked. Okay, and hypertrophy will not occur. That is the most common cause of mortality in CHF. So giving them will be more beneficial as compared to harm. I'm not saying harm will not occur. So there are definitely risk and benefit both occur with all the drugs, but we have to wait. So here benefit is more as compared to risk. You got it, Himalaya. You got it. So that was a very good question that I was going to tell you when I was giving you the detail of all of them. How many of you got it? So say people say the 6 categories of drugs used to treat the heart failure. First, you learn the classification. Students even don't know the classification. If I ask, tell me the drugs, the 6 categories of the drugs for the heart failure. You can't enumerate the 6. You don't understand because. So what are the 6 categories of the drug we use for treating heart failure? Most of you knows only one drug, inotropic drugs. Inotropic drugs. Inotropic drugs are the drugs that increase the contractility. But what about the remaining 5? The remaining 5 are reversing the compensation. You can understand it if you know this. So first is inotropic drugs. Inotropic drugs that increase the contractility. The second is alpha and beta blocker. Alpha blocker, we don't give much. Better than alpha because alpha blocker is having many side effects. We don't give. Just to enumerate, I'm telling you, but I will not teach you alpha blocker over here. We give vasodilator. That is much better to give than alpha blocker. Because if we block alpha, there are many other organs also having alpha receptor. That all will be getting blocked. Okay, and side effects will be much. But rather than alpha blocking, we can do, but we don't do practically. We give vasodilator. So we can give alpha blocker, we can give vasodilator, we can give arteriodilator, venodilator, both dilator, mixed dilator. We can give all dilator. We can give beta blocker. We can give RAAS inhibitor. We can give aldosterone antagonist, and we can give diuretics. Have a look. So these are the 6 classes I am going to teach you one by one. You can mark the 6 classes over here. This is the problem which is happening. So you can see the left ventricle is contracting less. That is the problem. That is not a problem actually. The compensation of that is the problem. God is doing the compensation. God is trying to do the good, but actually bad is happening in long run. God is always great. God does nothing bad for us. I believe, I'm having a strong belief in that. So suppose someone heart is failing, God is trying to save the person by acutely releasing noradrenaline in the body that will go bind it with the beta 1 receptor of the heart and save the person at that time. But person should take the treatment after that. Person is not taking the treatment for long, and this noradrenaline present in the blood for long, then it will go and bind here also, bind here also, bind here also, and that will lead to hypertrophy of the heart, and the person will die after many years, but not acutely. So acutely it is for compensation, but chronically this compensation is not good. Okay, this compensation is good for acute saving the person, but for chronically this compensation is not good because this compensatory mechanism is leading to left ventricular hypertrophy, which is the most common cause of mortality in congestive heart failure. You got it? Now let me mark the 6 category of the drugs over here. Can you help me with the 6 categories of the drug over here? The first category of the drug are inotropic drugs that increases the contractility of the heart. Number 1. Okay. Number 2, I will say alpha blocker. Alpha blocker. Number 3, I will say beta blocker. Okay. Number 4, I will say RAAS inhibitor. Number 5, I will say aldosterone antagonist. Aldosterone antagonist. Number 6, I will say diuresis. And you can say here also alpha blocker ki jagah vasodilator, venodilator and arteriodilator. That is vasodilator. Okay, can we go ahead? So these are the 6 classes. How many of you got it? The 6 classes. Can we start the chapter? I'm starting the chapter. Please allow me to start. Mechanism of action, I already explained you all 6 together in one shot. In one diagram, all 6 mechanisms are clear. Now I will give you the flowcharts of all 6. Okay, so these are the 6 categories of the drugs we have to cover in detail one by one. So first we will start with inotropic drugs, which are most important drugs over here. Inotropic drugs. Then we will move on vasodilator, then RAAS inhibitor, then diuretics, then aldosterone antagonist, and then finally beta blocker. In this sequence, we are going to cover these 6 classes under a fixed set of heading. I guess most of you know my way of teaching. I teach you the drugs in a fixed set of heading and I call them master chart. First of all, I will let you know the introduction in each category, then drugs in each category. You should know the classification. You know the broad groups, but you should know the drugs in each category. Name of drugs in each category. You should be able to learn that. You should know the mechanism of action. Broadly, you have understood it. In this diagram, you are understanding the mechanism of all 6 categories, but you should be able to draw their flowchart with the diagrams. You should be able to tell me the uses. Of course, the uses heart failure, but is it acute heart failure or chronic heart failure? And apart from heart failure, any other uses are there? You should be able to enumerate that, and side effects or contraindication, if any. So this is the way you should study. I hope we are halfway done. Can we start? Show some interest, people. So let's start the first category. Now listen. Among them, the first 2 are ultra important. The inotropic drugs and vasodilators. Okay. Inotropic drugs are of 3 types. So we will further divide this column into three categories. These are the three type of inotropic drugs: cardiac glycosides, sympathomimetics, and PDE, phosphodiesterase 3 inhibitor. Phosphodiesterase 3 inhibitor. So we will further divide this column into three categories. The three categories. Vasodilators we will come. Vasodilators are also of three type: arteriodilator, venodilator, and mixed. Mixed mane both. So again, we will divide this column into three categories. I will teach you first arteriodilator, then venodilator, and then mixed dilator. RAAS don't have any category. I will teach you here. Diuretics here only, aldosterone antagonist here only, beta. So we are having these two drugs. We have to further divide them in three categories. Let's start the inotropic drugs. Can I start with the first category? Let's start. So let's start inotropic drugs.
Hello everyone. I hope you found this concept clear and easy to understand. If you would like to dive deeper into this topic and master it with full-length lectures, you can subscribe my app, that is MedLive by Dr. Priyanka. So join me for the live sessions where we break down the complex topics in a way that makes them simple and high yield for exams. See you inside.